Pulmonary edema is the abnormal accumulation of extravascular fluid in the lung parenchyma and alveoli, leading to impaired gas exchange, decreased lung compliance, and hypoxemia. Pathophysiologically, it represents a severe disturbance in the normal hemodynamic and permeability barriers governing fluid exchange across the alveolar capillary membrane. Fluid movement across the pulmonary capillary endothelium is dictated by the Staverman modified Stalling equation or the revised Stalling equation. JV is equal to Kc into Pc minus Pi minus sigma into pi c minus pi 1. That's the formula, of which JV is net fluid filtration rate across the capillary membrane, Kc capillary filtration coefficient, hydraulic permeability of the membrane, Pc capillary hydrostatic pressure, Pi interstitial hydrostatic pressure, sigma Staverman's reflection coefficient, and index of the membrane's barrier effectiveness against plasma protein. Pi c capillary oncotic pressure, primarily driven by plasma albumin. Pi I interstitial oncotic pressure. Under normal physiological conditions, the net filtration pressure is slightly positive, driving a constant, highly regulated trickle of fluid into the interstitial space. This filtered fluid is continuously cleared by the rich pulmonary lymphatic network. Pulmonary edema develops when the rate of extravasation exceeds the maximum clearance capacity of these lymphatics. Pulmonary edema is broadly divided into two major pathophysiological phenotypes based on which variable in the Stalling equation is disrupted. Here is a comparison between cardiogenic and non-cardiogenic pulmonary edema. Primary mechanism: elevated capillary hydrostatic pressure in cardiogenic, increased alveolar capillary permeability in non-cardiogenic. Pulmonary capillary wedge pressure elevated greater than 18 mm of mercury in cardiogenic, normal 18 mm or less in non-cardiogenic. Edema fluid transudate, low protein content in cardiac. It is exudate, high protein content inflammatory cells in non-cardiogenic. Classic etiologies: left ventricular decompensation, severe mitral aortic valve disease, or acute myocardial infarction in case of cardiogenic pulmonary edema. In non-cardiogenic, it is ARDS, severe sepsis, aspiration, pulmonary contusion, or smoke inhalation. Radiographic signs: cardiomegaly, upper lobe venous diversion, curly V lines, and perihilar haze in cardiogenic pulmonary edema. In non-cardiogenic, normal heart size, patchy peripheral or diffuse bilateral infiltrates. Intrinsic safety factors. The human lung possesses three distinct physiological buffers designed to prevent rapid alveolar flooding when capillary pressures begin to rise. 1. Lymphatic acceleration. Pulmonary lymph vessels can increase their flow rate by up to 10-fold in response to rising interstitial volume. Interstitial compliance. The loose connective tissue spaces surrounding the bronchioles and pulmonary vasculature, the peribronchovascular cuffs, act as an expandable compliance reservoir. Fluid pools here first, the interstitial edema phase, before disrupting the tight junctions of the alveolar epithelium. Active alveolar clearance. Alveolar type 2 epithelial cells actively transport sodium ions out of the air spaces via apical epithelial sodium channels and basolateral sodium-potassium ATPase pumps. This creates an osmotic gradient that continuously reabsorbs water back into the interstitium. Alveolar flooding, the alveolar edema phase, only occurs once these three safety mechanisms are entirely overwhelmed, causing fluid to breach the epithelial barrier and fill the air spaces, abruptly halting regional ventilation.